All right. Thank you, Ms. Knox. Good afternoon, everybody. Before we start, this is my second time up here, and I just wanted to point out Ms. Knox and her team, who have done such an incredible job, and I think are such a blessing to our community here. So I'd like you guys to give her a round of applause, a big round of applause.
Thank you.
Because it's through her efforts that we're actually able to bring some standard of care that has been going on in the rest of the country and the rest of the world here to Meridian, so that we can get everybody here things that are being done that are cutting edge now. So with that, I'm going to talk to you a little bit about lung cancer and lung cancer awareness. And the reason why we picked this topic was November was Lung Cancer Awareness Month. And we just came out of that month. We advertised, and it's very important because we do live in what's referred very colloquially as the tobacco belt of the United States. So there's a lot of smoking, there's a lot of lung cancer in this area. So I have a short PowerPoint presentation, and I'd like to go over a few things, and at the end of that, we'll take some questions as well. Okay. All right. So I don't have any disclosures, any conflicts of interest. We can go on to the next slide. So there are a few facts about lung cancer. The most common cancers in females are breast cancer. The most common cancers in males are prostate cancer. And in both males and females, the second most common cancers that we encounter are lung cancers. Next slide, please. However, lung cancer is the #1 killer in the US. So it is the cancer that causes the most deaths, even above breast and prostate, despite it not being the most common cancer. It is the cancer that causes the most deaths, and that's why it's so important to deal with this. Next slide, please. The risk factors for lung cancer, the top 3 risk factors for lung cancer are smoking, and smoking. So those are the top 3, and that is a modifiable risk factor. And all of our lung cancer screening guidelines come from smoking history. And the tobacco companies over the last 50 to 80 years have had a very successful advertising campaign, so that 30, 40, 50 years ago, before these things were known, we became addicted to it as a community, to tobacco and nicotine. So it's important for us to understand and realize that those things were meant to be addictive, and they did a successful job, and we are now battling the consequences of that. Next slide, please. Why is it important to detect lung cancer early? As you can see up on the slide there, lung cancer, if it is picked up early, can be curable. And everything that we do is to pick it up early. And you'll see a common theme in my talk is that by the time you feel symptoms of the breast cancer, unlike breast cancer, you're not going to feel a lump in your lungs, right? Unlike prostate cancer, you're not going to have urinary difficulties. A lung cancer, when it is an advanced stage, only then will it become symptomatic. I have a cough, I'm coughing up blood, I'm losing weight. These are some things that patients with lung cancers do. So we have to be a little bit more aggressive in how we attack and approach lung cancer, and we'll talk a little bit more about that today. So what is screening? Screening is a test done to detect that cancer before the actual clinical symptoms develop. And like I said, a lot of those symptoms will not develop till it is advanced disease. And before now, and now being the last decade or so, why was this thing not done routinely for patients, just like when you go to get your mammogram done, or when you go to get your prostate examined, or when you go to get a colonoscopy done after the age of 50? Why was lung cancer screening not up there? And that was because we did not have good data. Next slide, please. So in 2002, this is almost more than 20 years ago, somebody realized this and said, look, we need to fix this. So they did a 5-6 year long study where they took 50,000 patients who were between the age of 55 and 74, who were either current or former smokers. And they said, look, let's try and scan them regardless of whether they have symptoms or not. Let's do a CT scan or a chest x-ray. A chest x-ray is a very basic test. It doesn't give us a lot of information. But the CT scan, for those of you who might have had one or had a loved one who had a CT scan, is a very quick test, but it gives us a lot more information. So what they found in that big trial that they did was that the ones who got the CT scans when they had a history of smoking had a 20% decreased risk of dying from lung cancer. And we do some statistics and math here, but it says that in order to detect one cancer, you need to screen 320 people. So that's a little bit of math. To give you an idea, for breast cancer, to detect one breast cancer, you need to screen about 13 to 1400 people. So it's very cost effective for the government and the insurance companies and healthcare costs that you will be picking up a lot more lung cancers compared to even the most common cancer, which is breast cancer in women. Next slide. Thank you. So basically, this was the first time, and this was a big paradigm shift. In 2010, the guidelines changed, the insurance guidelines changed, and said now lung cancer screening must be part of your evaluation because we can act early, we can save lives. And that is very, very important for us in the medical community to be able to say something with that much confidence. Next slide. So the question then is, who should get screened? And the screening is something that your primary care physicians should be on top of, but it is also important for us as patients to advocate for ourselves or our family members. So if you know someone who's between the age of 55 and 80, who's either a current or a former smoker, and who smoked at least 20 pack years in their lives. What's a pack year? A pack year is if a patient smokes 1 pack of cigarettes a day for 1 year, that's 1 pack year. So 20 pack year history. Now, if a patient smokes 2 packs of cigarettes a day for 10 years, that's also a 20 pack year history of smoking, or half a packet of cigarette for 40 years is also 20 years. So let your doctors and your nurse practitioners do the math for you, but if you are at risk for that, bring it up to them, right? And there's a little bit of a kind of a little infographic that basically shows, we have this up in our clinics, we share this out in the community as well, so that this is a nice quick snapshot to know, but it basically goes over all the same information that we just spoke about. Next. So what is this? This is lung cancer screening with a low-dose CT scan. So you go in, you get this scan done, it gets interpreted by a radiologist and a lung doctor, and then based on the findings, they will go ahead and either act on it or say that another scan can be done in X amount of time. Next slide. What is the benefit of it, right? It has to be cost effective for the government and the insurance companies and all to pay for, but more importantly, it needs to be done because we can pick up on those cancers a lot earlier. When they did a study, they found that nearly 7 million Americans qualified for lung cancer screening as of a few years ago. But less than 4% of them had even gotten a low-dose CT scan to actually rule in or rule out lung cancer. And that is an astounding number, that we're missing 96% of the patients who would be eligible to get the screening done. And that, it scares me a little bit, which is why we're putting out these talks and always pushing the envelope to our community outreach as well. Right. So everything that gets done, every test you do, every blood test, etc., comes with either risks and benefits. We know what the benefits are. So what are some of the risks of the study? And risks are not just physical risk to your body, but more so, what are the risks if it comes back as a false positive? That means that in the studies we know, if you picked up 10 random people out from the street, you just went out today, went to Winn-Dixie or Walmart and said, hey, 10 people, come with me, I'm going to scan 10 of you, regardless of their history. 2 to 3 of them might have a lung nodule or a spot in the lung. But that doesn't mean that all of them need biopsies, all of them need risks. That basically means that they have spots in the lungs that could be anything. It could be nothing, it could be an old infection, or it could be a lung cancer. So based on that, we know that there are these false positives. The vast majority are not lung cancer, but your physicians will go ahead and make that determination for which patient needs next steps on that. There are also false negatives. Just because you got that one scan done doesn't mean you cannot develop lung cancer in the future. So if your scan was normal, your physician might repeat one in 1 year just to make sure that you're doing okay. All right, next slide. There is some radiation exposure, but when you guys go and get a normal CT scan, that is almost 4 times, 5 times as much radiation as the low dose CT scans that we order. So because this is a screening test, because some of the patient population might need this every year, it's important for us to give you less amounts of radiation. And hence, it's called a low dose CT scan, right? And then, we're always dealing with insurance companies and they will cover this, and so will Medicare and Medicaid. Next one, please. That's what the scanner looks like nowadays. It's an open scanner. There is no IV contrast needed, so you don't need an IV line. You get in it, it takes less than a minute. For those of you who are slightly claustrophobic, it's slightly more of an open machine, so it's very well tolerated by most of our patients. Next slide, please. Okay. So what happens if those results come back? You can have one of 3 possibilities. You can have a negative scan, which means that everything is fine, I'll see you back in a year because you're still at risk. You can have a positive scan, which means that, okay, a nodule was seen, what should I do about this nodule? And your physician will look at your history, what the nodule looks like, where it is. We have a lot of data and research that we train on to be able to guide you guys. And then finally, the last one will be, okay, it's a positive thing, I see a nodule, it looks very, very suspicious for me, we need to do something about it. Next slide. So if that suspicious nodule comes around, there's one of a couple of things you can do. Your doctor may say, you know what, you were recently sick, I think this might be pneumonia, I'm not sure, but let's repeat another scan in 3 to 6 months. They may say, well, I need more information. I'd like to get another special type of a PET CT scan to see if any one of these nodules are active or not. If the nodule is inactive, it's very, very less likely to be cancer. And they finally might say, you know what, this is a very suspicious lung cancer. Let's not take a chance. Let's go ahead and get a biopsy done. Next slide. So there are 2 methods to biopsy a lung nodule. So when you have a little spot on the lung, how do you get to it? And this is where the state of the art kind of comes into what we're talking about. Prior to maybe even 6 months ago, here in Meridian, we used to have a spot in the lungs, and the radiologist would put a needle from the outside. They would give you some medication to make you sort of somewhat sleepy, and they would put a needle from the outside that would be a little bit painful, but they would try to get a diagnosis. And then based on that diagnosis, they would get treatment or so. The risk of you having a lung collapse, because imagine putting a needle in a balloon and having the lung pop, was about 25 to 30%. So over the last decade, they came out with something called robotic bronchoscopy, where you go to sleep, it doesn't hurt because we go from the inside and we can actually make our way all the way to that spot in the lung. You can go over to the next 2 taps on the slide. One more. Right there. So we build a roadmap of your lungs. This is here. This is available as of today at Oshner Rush. We build a map of your lungs, just like you put into Google Maps or GPS, if those of you used it. It tells us that the destination is the lung nodule, and we can actually drive to it. So we do this robotic bronchoscopy where we can drive to that. We can make a diagnosis once we get to the lung nodule, and we can look at your lymph nodes all in the same procedure while you're completely asleep, while it does not hurt. And the risk of you popping a lung during that procedure, whereas it's 25 to 30% with the one from the outside, from the inside it's only 2 to 6%. So it's considered a relatively safe procedure, and we do this every week at our hospitals as well. So this is to show you, okay, well, doc, I'm getting all this lung cancer screening done. What do we do next? Well, the answer to that is we're actually able to go down and sample these today in your city, in our city here in Meridian. And to me, that is an incredible accomplishment. And we've done almost 100 of the other type of cases as of a few months ago. So next slide, please. Insurance-wise, most of them will cover it because it's part of national guidelines now. This is not kind of an optional thing anymore. This is your health. This matters. This is now part and parcel of your annual health screening. So this is not one of those, I could, I should. This is one of those, if a patient meets criteria, they must. Next one, please. What happens if a patient is diagnosed with lung cancer? This is a question I get with a lot of patients who come in. The first thing is we need to determine what type it is, see if it has spread anywhere, and then see what options there are. And we have some great oncologists here right across the street from our hospital. We work very closely with them. They try to keep you local for everything that they can do here. If not, they will refer you to Jackson for some treatment or so. And that's important for us because we can work as a team to try and get the community here as much treatment locally, which is what we all want. I don't know about you, but I'd rather not drive like 90 minutes or 2 hours or 3 hours somewhere when I can be close to my loved ones, have them take care of me. And so that's very important. So we keep pushing the needle on that to make sure that we can keep our care local to Meridian, which is important to us at our hospitals. Next. There are two types of lung cancers. The simple thing is one is small cell, one is non-small cell. Small cell is a more aggressive type. We still treat it. Non-small cell is a less aggressive type. Also, small cell is more related to smoking, whereas non-small cell is more related to non-smokers. But this is just out there to put some information there. Maybe you've had a family member or a friend or a loved one who's been diagnosed with one of these. So this might be familiar to you. Next slide. This to me was a very, very important slide. On the top left and on the bottom right, you'll see that lung cancer is most prevalent in the southeast of the United States. Mississippi is right there. It's highlighted as one of the major states where lung cancer is very prevalent. And that's because here in Mississippi, we haven't been as good as we should be about our lung cancer screening. Things are changing now, but it's through events like this, through educating primary care physicians and telling them, look, things have changed in the last 10 to 14 years, and now there's a different paradigm shift altogether. So to me, being part of this community now, it's been, 14, 15 months, and I consider myself a Meridianer, if that's how you call it. It's important to me to be mindful of the fact that we are in one of the highest regions in the country where there's lung cancer, and to make sure that we can go ahead and address that head on. Next slide, please. This again is a very important little slide to me. It's difficult to kind of see what the writing is since the slide is really far away. But one of the things where it says 10 years means that if a patient stops smoking today in 2024, it will take them 10 years till their risk of lung cancer goes equal to or the same as somebody who never smoked. So it's never too early to quit smoking. You can always quit smoking even earlier because it takes some time for your body to heal and for the carcinogens to not affect you and for you to have the same risk. And that's important. I show this a lot to my patients when I talk to them in clinic about smoking cessation and things like that. Next slide. That's our team. That I just put that up there so that you understand that that's a very small fraction of the people who will be taking care of you when you come. You're going to first encounter your primary care's office. Then you might see a specialist or so, but there's an entire team that is actually dedicated to lung cancer awareness, lung cancer screening, and lung cancer guidelines. So there's a little bit of an overview of lung cancer itself, why it's important, but more importantly, what we can do about it. Because I understand if things are important, but then what's the point if there's nothing that we can do about it? And today, as of December 2024 in Meridian, we have the ability to help diagnose those cancers, treat them here, and actually monitor those lung nodules. And it's something that we are personally very proud of. So thank you all for your support here, and I'll take questions now as you guys have them.